Hi, I'm Melissa. I'm an occupational therapy assistant student, and today I'm going to be going over two neurotherapeutic intervention or techniques, specifically PNF techniques, that I've been working on with a patient, and I will go over those and demonstrate those and the purpose of why we are using those techniques. So the patient that I have been working with, her name is Alice. She is 10 years post-stroke. The pathology of her stroke was, obviously they couldn't pinpoint it exactly, but she had had previous blood clots and had been on and off different medications trying to address that, been put on blood thinners, but not too long before her stroke she was switched to be put on blood thinners. So might have been caused by those blood clots. She had a left CVA, so the right side of her body was affected, both her right upper extremity, her right arm, and her right leg. Like I said, she's 10 years post-op. She was hospitalized for the first 2 to 3 weeks immediately after her stroke, and she had an intensive regimen of therapy. She had OT, PT, and speech therapy. She did say that it was most obvious, it was most important that she have the speech therapy. That was most crucial at that time, but it was the shortest amount of therapy that she had, because she was not able to speak, so she had some deficits in that post-stroke. And so after those 2 or 3 weeks, she was able to go home, continue doing therapy outside of the hospital. And she was first walking for the first 3 months after her stroke. She used a cane to ambulate and to walk, but she no longer, since that 3-month mark, in the last 10 years since then, she's not needed a cane. She can walk independently. Some client factors to address. She does talk about how sometimes she has some memory issues, some memory deficits, thinking of people's names. Sometimes it takes her a little bit. She makes it a point to say that if you hadn't known her before the stroke, you probably wouldn't notice it, but people that did know her, and her specifically, she does notice. Every once in a while she gets a little tripped up there. She also is having spasticity and tightness in her right arm. So she has range of motion there. She did even talk about how she can raise her right arm to about 90 degrees right here independently. She can't go higher than that unless she brings in her unaffected arm and lifts it. Then she's able to. So she has hypertonicity in that arm, some tightness and spasticity. She says that she never had any pain throughout the stroke and throughout the whole process, so that's good. She has discomfort, but she never had any pain. She is hypersensitive to temperatures in her right arm, specifically cold. She did mention that in the interview. And she's never had any numbness or tingling in her right arm. And then she mentions, even though it wasn't painful, when she flexes her elbow, she does have some bicep, this muscle right here, discomfort when she goes like this. So again, like I said, she has hypertonicity in her hand and that arm. She doesn't have full range of motion, at least independently, so we are working on that. She's not able to supinate this arm. If she comes in and self-assists, she can move it a little bit, but for the most part, she cannot supinate her right arm. And she has some little bit of wrist extension. Performance skills that we are addressing specifically are motor skills. So anything with that right arm, as far as whether it's reaching, grabbing, being able to lift, flex and extend, things like that. Anything, any mobility in her right arm, that's where we're focusing on. The principles of these PNF techniques that we are going to talk about is to promote that functional movement in her arm and those movement patterns. We want to work on rebuilding those neuronal pathways, and for her we want to help decrease muscle tone because she's very spastic. So that's what we're focusing on there. And then also motor behavior is expressed in a sequence. So one of the principles of PNF techniques is this idea, and the total patterns are expressed in a sequence of events. And also motor learning occurs when motor ability improves. So constantly practicing, constantly working on rebuilding those pathways and decreasing that muscle tone. So the first technique is D1 flexion and D1 extension. So D1 flexion is going to start up here, and then with the client's eyes as well, she's going to watch her hand go down into D1 extension. So right here, the shoulder is flexed, the elbow is flexed, the wrist is slightly flexed and radial deviation, and then she's going to come down into here and she's going to more extend that shoulder and pronate that arm and come out. So it's going to look like this, and then she's going to bring it out to here. Arm look pronated down here. So that's D1 flexion into D1 extension. The D1 flexion could be functional. So an intervention that we would do is this D1 flexion. We could have her brush her hair on the opposite side of her body. So right arm brushing on the left side. We could also, if we wanted to, work on eating and different things like that, and just bringing that arm into that D1 flexion. So that's an intervention we'll do with that. And then for the D1 extension, come down here into this, and this can be good for if she's pushing against like a car door to get out, or pushing up from her seat to stand up, things like that. So yeah, that's the intervention we would do. The first one, D1 flexion into D1 extension. The second technique and intervention that we would do with Alice is D2 flexion and extension. So D2 flexion starts here in the right side, and this will be her right arm, which is the affected arm. And for this, the shoulder is flexed, elbow is flexed, wrist is slightly flexed, and she could brush her hair on the same side, on the right side of her body. So we're coming from here, from D2 flexion, down into D2 extension. So she's going to watch it and come down, and that arm's going to be down here to her side like this. You want to make sure it's crossing that midline. So when it comes down into D2 extension, the shoulder is more the elbow is extended, the wrist is now in more ulnar deviation, and we have gone from supinated to pronated in the forearm. So those are the two interventions that we would do with her, working on creating those movement patterns and having her practice so that we're building those pathways and we're decreasing that muscle tone and trying to repair and return that functional movement through those functional movement patterns.